Good morning, good day, and good evening, depending on where you're joining us from. My name is Aasim Yusuf. I'm a gastroenterologist and chief medical officer at the Shaukat Khan Memorial Cancer Hospital in Lahore and Peshawar in Pakistan. It's a pleasure to welcome you today to this session entitled The Effects of the COVID-19 Pandemic on Cancer Treatment, organized jointly by the Shaukat Khan Memorial Cancer Hospital and the London Global Cancer Week. Shaukat Khan Memorial Cancer Hospital is a charitable institution based in Pakistan, built and funded by charitable donations, where we treat over 75% of our cancer patients completely free of charge. It's a pleasure to have Professor Richard Sullivan as our co-host today. He really needs no introduction to this audience, but just in case there is anyone who doesn't know of him, he's the director of the Institute of Cancer Policy and co-director of the Centre for Conflict and Health Research at King's College Hospital in London. I'm going to hand over to Richard to talk for a few minutes about the COVID-19 and Cancer Task Force, and then we'll go into the main session. Richard.
Aasim, wonderful. Thank you very much indeed. Ladies and gentlemen, again, a huge warm welcome wherever we are in the world. We're going to introduce our distinguished panelists as they go along in a minute. Thank you for joining us here at just coming towards the end of the London Global Cancer Week. We're going to share with you a little bit about some of the findings and insight from the COVID-19 and Cancer Task Force, and an absolutely remarkable collection of individuals. I'm going to share my screen now, if that's possible, to present a few slides, to basically show you, oops, a little bit of disabled screen at the moment, to show you a little bit of the extraordinary range of work from our individual partners within the COVID Cancer Task Force. You're going to hear a lot more from Raúl and Fawad and Debbie and Dorothy in a moment from their individual areas, but I want to talk to you a little bit about the work that actually has been done by the remainder of the task force. Let me start by saying that it was really a remarkable internationally represented group of cancer research leaders. We were set up in February 2020 with some of the leading senior clinicians spanning the whole of the cancer continuum, from high income settings all the way through to some of the most fragile economies. This was very much self-organized and self-funded. It was really an emergent group. We've published over 100 publications now, and again, many of these we presented today, had a very active, wide education dissemination program, and also a very wide spectrum of research across the globe. And I think that really, really represented something which was very, very interesting, because there was no doubt that the group itself were the first to actually understand the impact of the COVID-19 pandemic in terms of delays for diagnosis and treatment. Groups, for example, of our colleagues in Canada were the first to put together the meta-analysis looking at the impact and the delays of treatment to eventual outcomes, and showing that, so we can probably share some slides now, showing that this was going to be quite a devastating impact. And if I can put these up now, and if you can all see that, showing basically that actually the pandemic and the lockdowns were going to have really significant effects on our outcomes. And this was really important work, because it really reflected, I think, what many of us were experiencing around the world, that it was not just the threat of COVID-19 to our cancer patients, it was also the threat of the non-pharmaceutical interventions, and particularly lockdowns. We had a number of groups, particularly from India, for example, looking at the impact of COVID-19 on cancer services, and showing quite shocking data that a lot of cancer services around the world were seeing extraordinary either slowdowns or complete shortages. We saw cancer surgery in many parts of the world ceasing completely, and I think Dorothy will talk more about silver linings as well. We saw some real innovation as well within systemic anti-cancer center and radiotherapy in particular, as services adapted to the new reality. We had some remarkable work, both from our colleagues in Malaysia, but also from Turkey, looking at the economic effects. This was important because the COVID-19 task force was very aware that the economic downturns in many countries were causing real hardship to cancer patients, because they simply didn't have the funds to access cancer care and pay for their cancer care. And so a lot of this work was really instrumental in individual countries in changing policy, in providing some sort of economic cushion for the patients. There was an extraordinary range of work on the management of cancer patients within the pandemic as well. We saw work from India, the UK, from New Zealand, from Pakistan as well, from Dorothy in Zambia, looking at how individual ecosystems were adapting their cancer care pathways. And there were commonalities and there were some very big differences. And again, I think we'll talk a little bit more today about some of the universals we learned about in terms of our treatment pathways. But again, it reflected an extraordinary diversity and also the speed in which a lot of the colleagues on the task force actually were able to write things up. And coming to the end now, obviously once the vaccination program started, it was essential for us to start understanding what sort of impact vaccinations were making to our cancer patients and also to our healthcare workforce that were treating cancer patients. And we were really first out of the block in terms of understanding this from a global perspective, reflecting what many other people knew, which was deep inequalities in access and application of these vaccines to our respective populations. And again, it was used as policy making work from Debbie led in Lebanon, colleagues in New Zealand and Pakistan. Again, all this work fed in to a lot of policy decisions and discussions at the highest level. We also created, and this is now expanding very rapidly, a surveillance and modeling group led by Karen Canfell from Australia to look at cancer treatment, screening and prevention in collaboration with the World Health Organization, HQ and IARC. And this did an extraordinary job in terms of pulling together data and starting to look at modeling techniques that could be applied in specific settings. And out of that came a lot of national studies and systematic reviews. Some of these really are only starting to come out now. Others came out very early. And again, these were really critical in providing the research community and the patient advocacy community and also clinical community with the data they needed to understand the relative risk of COVID-19 patients and also the trade-offs with shutdowns. So final remarks. We've now done an analysis and 44% of all global research on COVID-19 cancer came out from task force members, which is amazing. Most of this was own account funding. Many research organizations were kind of absent without leave during the pandemic. So a lot of the work that's being presented today was because of the hard work of the individuals that were there in the individual centers. We do need to critically examine how well we really performed in respect of ecosystems. And I think what we see now, what you're going to hear, is there's a real need for a wide range of retrospective and prospective interdisciplinary studies to understand the pandemic. Why? This will not be the first or the last major global pandemic. Trying to future-proof our systems in terms of new epidemics at the country level and pandemics, transnational is going to be essential. And I think there's probably a real danger we'll end up sweeping a lot of the lessons and some hard lessons under the carpet in an effort to try and get on with life. So thank you all day for joining us. And really, on behalf of everyone, delighted to have you here. And I'm going to hand back to Aasim.
Thank you, Richard. That's really quite very interesting statistics about the publications from the task force in particular. And the take-home message, clearly, I think I agree, is that this isn't the first and it won't be the last pandemic. So very, very important lessons have been learned, I think, all over the world. Okay, so we're going to go on to the to our speakers now, and I would just point out that we have speakers from all across the world, ranging from Colombia, Bogota, Colombia, where it's 5 a.m. at the moment, to New Zealand, where it's close to midnight. So I'm very grateful to all our distinguished speakers, and we're going to, I'll just introduce them one by one as in the order they're going to speak. And because it's very early in the morning, we're going to ask Dr. Raúl Murillo from the Centro Javeriano de Oncología in Bogota, Colombia. Dr. Murillo is a distinguished member of the task force and a professor of medical oncology in Colombia. So Raúl, it's over to you for your presentation. Thank you.
Thank you, Sim. Thank you for the invitation, Richard and Aasim. It's my pleasure to be here. And I'm going to present right now. Sorry, I didn't get that. Yeah. You see my screen?
Yes.
Yes, you do. If you can put it into presentation mode, Raúl, that should be perfect.
Okay, it's fine. So thank you for the kind invitation. I'm going to talk about the behavior of the oncology service demand during the COVID-19 pandemic in Colombia. And I have no conflicts of interest to declare. And this data have been already accepted for publication in a Colombian journal, which is Columbia Medica, but it is available on PubMed, so you can see the data in more detail if you wish. So this is the content of my talk. Let's start talking about the Colombian health system, which is a bit quite complicated, but I'll try to simplify the information and the characteristics of the Oncology Center as a context for the data I'm going to present. So the Colombian health system is essentially an insurance-based health system with two main insurance plans, one for workers and their families, and one for low-income population without payment capacity. We have a 95% coverage of the insurance plans for the Colombian population, so we can say that we have universal health coverage for the insurance health insurance in Colombia. We have a benefit package which is defined by the Ministry of Health, but the benefit package is actually administered and managed by the insurance companies that could be exclusive to the contributory system for workers or exclusive to the subsidized system for low-income population, or there are some insurance companies managing both kind of populations. And the provision, the delivery of healthcare is done by public hospitals or private centers, no matter if they are attending people from the contributory regimen or for the subsidized regimen. But I have to say that almost 90% of the oncology care is provided by private centers in the country. And before talking something about the Javeriano Oncology Center, let me talk briefly about the behavior of the cancer in Colombia, the occurrence of cancer in Colombia. So the main causes of cancer, the cancer incidence are breast and prostate cancer in our country, followed by colorectal and stomach cancer. But the main causes of cancer deaths in our country are actually stomach cancer and lung cancer. And those are the four types of cancer: breast, prostate, lung, and the stomach, that I'm going to present some data about the changes in the stage of disease and diagnosis during the pandemic. So this is the characteristics of the Oncology Center. I'm not stopping here just to tell that this is a comprehensive center providing cancer care for cancer patients. We're a private nonprofit center, and just as a context again, we have two main sources of data from cancer in our country. One from notification system from insurance companies to the Ministry of Health, and one estimated numbers by the National Cancer Institute. For Bogota, they estimated between 9,000 and 11,000 cancer cases per year. And the notification system reports that 46%, almost a half of cancer cases, are from the contributory regimen, which is representing more or less the coverage for the insurance plans in our country. So the reported new number of new cancer cases in our center for the year 2021 was almost 2,000. So meaning that we are a good representation of the contributory regimen in Bogota, since we receive 75% of our population from Bogota, and our population is 95% from the contributory regimen, the insurance plan. But I have to say also that in most capital cities in the country, about 28 out of 36 capital cities have comprehensive care. So I would say also that our data represent the contributory regimen for the whole country. This is the behavior of the COVID-19 pandemic in Colombia. You see that the beginning of the first case was reported late March. So the confinement started in April, and it was very long until the end of August. And the first peak on the pandemic was in August. So just after the first peak of the pandemic, the confinement was released. And we have a second peak of the pandemic in December, just to show you the relation with the demand of oncology services in our country. Well, this is the data. We use a methodology which is called endemic channels, usually used to detect outbreaks of a disease. So normally the alarm zone is on the top, not in the bottom, but we use the opposite to see a significant decrease in the demand of oncology services. So this is for new consultations, new patients consultations, and for the treatment delivery for the new patients. In general, what we saw is a common decrease for all services at the beginning of the confinement during the month of April, but most of them actually recovered very rapidly after the first month, exception made of which is we call clinical oncology, with the provision of consultation for solid tumors. And here, the delivery of treatment, this is in-hospital chemotherapy, this is outpatient chemotherapy and radiotherapy. And again, so there was a decrease, but it was a sustained decrease, but in-hospital chemotherapy, systemic therapy, outpatient chemotherapy remains to the bottom of the secure zone, but not a significant decrease. And radiotherapy was always, all the time, within the secure zone. So this is data not based on the endemic channels, but there's a only percent change. It allows us to compare between different services the magnitude of the impact. And you saw that the services with the highest impact was the hematology, which is mostly, related again to in-hospital care and palliative care. We also are providing information on the year 2021 and a couple of things to highlight regarding new consultations. The first one is the rapid recovery for radiotherapy and even an increase over the previous years. That's we think is essentially the movement from patient from surgical management to radiotherapy management, and prostate cancer is something that which is very relevant to radiotherapy because most of the cancer patients are coming from this kind of disease. And the other thing to highlight is the increase of palliative care in 2021. So after the pandemic, after the crisis, public health crisis. We think this is maybe reflecting the movement of to late disease for many cancer patients. Actually receive a request from the insurance companies to receive cancer patients, not only from our center, but from other cancer centers in the city and in the country, given the high demand after the crisis for palliative care, so reflecting maybe a later state of the disease after the crisis. And regarding the delivery of treatment, we saw essentially is a sustained decrease in the demand for in the provision of in-hospital chemotherapy. And here we have surgery, which was not in the previous slide because we didn't have sufficient data for estimating the endemic channels for surgery. But based on the comparison with 2019, what we saw again was a significant decrease and sustained decrease during the whole year. So you see the other services don't have the same behavior. And the reason we think is in the case of in-hospital chemotherapy or surgery chemotherapy, we have competing resources with the COVID-19 patients because we don't have enough beds for all the patients, and we don't have enough beds in intensive care units for doing surgical oncology. So that the reason those services were the most affected by the pandemic. Some data about the demographics. So that's the great impact for all the population, which is, not surprising, given all the high risk for those populations and the instruction to stay home for those populations. Something interesting is the higher impact for females, for women. And we think this is related to the social role of women, not only regarding the disease, but also the need to stay at home with children, or kind of social roles that may be impacting in a greater way women than men during the year of the pandemic. So the control visits, we didn't have so much changes. Radiotherapy is essentially reflected the same behavior as the new consultations because we kept one-to-one visit, meaning that the one new patients, we just follow those in the presence visit for one time. And differently for the other kind of consultation, we reduce the number of consultations by prescribing longer periods for the chemotherapy. So it was a different impact for the control visits and a rapid recovery for the year 2021 as well. And finally, data on the stage of disease, which is interesting. What we saw is a decrease in early stage of disease for breast cancer, which is sustained during the year 2021. So we also saw a decrease for stomach cancer, which is also more or less sustained during the year 2021. So we didn't see a major impact for prostate cancer. Prostate cancer is a different kind of disease. The biology is different and the behavior of the disease is different. So we thought that no major impact for that. But for lung cancer, it was interesting to see a small increase, not significant, but a small increase of early disease for lung cancer. And we think it's related to all the work we did doing the images for the chest during the COVID pandemic. So it allowed us to detect a bit more early disease during the period of the pandemic. But again, we have a very low rate of early disease after the crisis. And we think the impact of, I'm sorry I didn't mention that before, but for breast and stomach cancer may be more related to the kind of early diagnosis and the work on the early diagnosis in the country. You see here, this is not data from our center, but from an insurance company having national representation. The screening for cervical cancer for breast cancer was absolutely stopped during the whole time of the confinement. And also the diagnostic workup for cervical cancer was stopped the same manner, but different for breast cancer. The diagnostic workup for those that have been already detected with that suspicious mammography was recovered more rapidly than the mammography itself as a screening method. So as a closing remark, I have to say that despite we have no changes in service supply, oncology services will always prioritized within the country. The confinement induced a significant reduction in service demand. The speed of recovery and the absence of a significant decrease to the subsequent waves of the pandemic. December, we didn't have the same effect on December. I think it's suggesting the patient resiliency, but the impact of having universal health insurance in our country. We observed significant variation for the pandemic by cancer type, service type, and population demographics. I think the proper response to future emergence should consider particularities of the population groups in order to reduce the negative effect of a general and unselective response to the pandemic. And one of the limitations of our work is the restriction to Bogota and the contributory regimen. As I said, we think is a representation of the country in the contributory regimen, but the subsidiary regimen could be different because despite having financial coverage with the insurance, it's different for a person with a stable employment to ask permission to attend a consultation, a medical consultation, but for a street vendor to stop his activity on the street to go for a medical consultation. So we think that despite I don't have data here, the pandemic induced greater inequalities regarding the oncology care in our country. Thank you so much for your attention, and thanks for the research team. Here is a picture of one of the Colombia wonders called the River of the Seven Colors. It's not a Photoshop, but something to invite you to visit our country. Thank you so much.
Thank you. Thanks very much, Raúl.
Amazing.
Very interesting talk. Before we maybe open questions with Richard, just to say that there are a number of people obviously on Zoom as well as on Facebook, and we would invite them to ask any questions they wish through the chat function on both of those. So we look forward to hearing from them as well, from the audience. But Richard, do you want to?
Maybe just one question before we sort of go on to our next speaker, Raúl, is what do you think needs to be done now? I mean, you present some amazing research you're doing, but I guess if you were to sort of step back now and say what the research we need to do to understand, for instance, the bounce back and resilience, etc., what would you like to see as a future research program that would be useful for Colombia?
So you mean regarding the public health emergency, like we had during the pandemics? So I think there's some issues that we haven't done yet. Is that we did a lot of changes and selective changes, as I mentioned, that trying to protect patients and trying to preserve the oncology care in place. But as I said, I think the impact of the pandemic is not the same for the whole cancer universe. And we're trying to investigate right now is all those changes we made, like changes in the treatment regimens, changes and delays on the beginning of the treatment, changes of in the modality of treatment, and we don't know exactly the impact we had on that, and how much it was actually needed, and how much it was actually protective for patients against the COVID. I think something we should elucidate for the future and understand better if it is necessary, if it is safe or not, and if the cost benefit is actually good.
Just one quick comment and a question. Very interesting. That's an additional silver lining, I think, that no one else has picked up, the increase in early stage lung cancer that you found.
Yeah, that was quite interesting. That was quite interesting because we have very late stage disease, as most of the world actually have in lung cancer. But I think all the work we did in images on the chest, because the symptom, the respiratory symptoms, allowed us to increase a bit during the pandemic. You saw it was exactly during the pandemic, and after that we get down again to the very low. centers of
I think we're going to discuss with Dorothy separately. So an additional silver lining. Just one other question. So have you caught up now with the shortage of beds, limiting surgery and inpatient chemotherapy and so on, and screening? Are you back at pre-pandemic numbers now?
We're back to that with surgery. We're back to, and with in-hospital chemotherapy, we don't have the same numbers yet. We're not sure what the reason. Something with the in-hospital chemotherapy is that the offer is not elastic. I mean, we have a static offer because we have the number of beds. It's difficult to increase the number of beds just to increase the offer for in-hospital chemotherapy. We're not sure about it. We haven't changed any of the contract with the insurance company. The population is the same. The insurance companies having relationship with us are the same, the biggest in the country. So we're not sure about that, but for surgical oncology, we're actually recovered to the previous numbers easily. And this year we're having an increased number as well, which is a bit not coherent with the palliative care because, surgical oncology is mostly for early disease than for late disease. So the number have increased in 2021, but palliative care increased really dramatically. I mean, so it was really a huge increase. And as I mentioned, I think it was due to the later stage of the disease and the demand from the insurance companies to receive patients from other cancer centers to take care with us. But the surgical oncology is already recovering. In-hospital chemotherapy is not. We're not sure about the reasons. Just to say that the offer is static, is not elastic.
And I think that increase in palliative care is the sort of long tail effect of the COVID pandemic on cancer treatment, isn't it?
Yes.
Okay, well, thank you very much, Raúl. We're going to move on to our next speaker now. Dr. Dorothy Lombe is a consultant radiation oncologist and health systems researcher at Health New Zealand, and she's going to be talking about the silver linings of the COVID-19 pandemic with accelerated steps to vaccine production in Africa. Dorothy, over to you.
Thank you very much, Aasim. As you have introduced me, my name is Dorothy Lombe. I'm originally from Zambia and actually experienced part of the pandemic there. And the work that I did as a member of the COVID-19 and Cancer Task Force was actually based in Zambia. So today I'm going to share some of the work we did as the task force. And basically, it's about silver linings. And as you said, as you think about things more, there are always a lot of silver linings that you can pick up in a crisis. A bit of background about how my attitude towards this is third world countries or developing countries, however politically correct you want to put it, are always in a state of crisis. So as a professional, you tend to improvise or try to look at the positive things as you experience life. And COVID kind of gave us that blank check to actually explore those things that we usually have bureaucratic issues and full stops on. Some of the work we've done, Richard shared a paper we did that talked about, increased digital use, education, virtual conferences, some of the things that Raúl spoke about right now. But I think something that is really significant on a really large scale was the accelerated steps to vaccines made in Africa. Now, as we all know, obviously, the pandemic was declared by WHO on 11th of March, 2020, historic moment for all of us. Sadly, it's still an ongoing pandemic. Here in New Zealand, where I am, it's still very much, we have restrictions, for example, in healthcare systems. So it's still very much a reality. Of course, in the face of vaccination, as we're going to discuss in this presentation, morbidity and mortality is not so great, but that can't be said about Africa. Because of the non-pharmacological interventions that were the cornerstone of actually preventing further spread or mitigating the outcomes of the pandemic, there were severe social and economic disruptive issues in a lot of countries. And this actually led to political instability in a lot of countries. So the consequence and the collateral damage is quite massive. Fortunately, the vaccine was actually approved since December 2020, and would like to explore how this played out for the African continent. Now, as we mentioned, we did a lot of work as the task force, and we met literally every week, and our work was centered not upon theory, but upon experiences and something that is useful, that could be used with the aim of documenting for the current crisis, but also to gain valuable lessons to use in future crises. And I think one of the best things that we could do is collect data and have that as a stored and accessible form so that people can actually refer back to it when formulating policy and just basically to look at experience. So one of the things we did was a rapid review. We submitted a comment on this rapid review 6 months after the vaccine was available. And our major concern, honestly speaking, particularly in emerging economies, was the fact that cancer patients are not particularly the priority of most of these environments. You've got infections, you've got maternal health and pediatric health that typically takes the forefront, and cancer patients are given secondary priority in practically all health issues. So we were worried that we know that they are actually more prone to severe disease due to their age, the treatment that they get that compromises their immunity, even just them working up an immunity once they get vaccinated is an issue. We were worried that the sort of like limited access that cancer patients would have would be high impact if we didn't amplify this to our community and our health systems. We were cognizant of the fact that at that time, COVAX seemed like a promising program. It only covered 20% of recipient populations. And by the way, there were some countries that were depending 100% on this because they just didn't have the mobility of funds to invest into procuring vaccines and so on. So what our rapid review found, the top of the chart is actually showing low and middle income countries. The green boxes show who had access or some form of promise to access to vaccinations. The lower part of the chart shows high-income countries, and you can see universally high-income countries had some form of access to vaccinations. Most of them had their healthcare workers vaccinated, and most of them also had their cancer patients prioritized because they had enough vaccination and could plan for it, and that would eventually roll out. The top part of the chart, which shows low and middle countries or representation of this cohort of countries, actually shows that a lot of countries did not prioritize their cancer patients. And when you think about representative countries, for example, Nigeria, which is our most populous country on the subcontinent, or Zambia, we didn't have data from there. And basically, it was because we were not sure when we were going to get the vaccine. Of course, there was this promise of availability, but when was it actually coming? Experts who we were interacting with couldn't tell us when this would actually happen, and this was an issue. The other thing that was important for us to contribute into the management of vaccination was whether this was a national strategy versus whether it was something that was being done at local level. And when you're in an organized health system, this is easy to take for granted. But the fact that that requires extra expertise and for actual prudent use and so on, you'd need to have something organized more at a national level and then distributed was also very important to acknowledge. Now, fast forward, countries are getting vaccines in and so on and so forth, however they're getting them in. What were the challenges to achieving good vaccination coverage in Africa? So the first thing that has come to fore, still talking about it, is just the inadequate supply of vaccine. We just didn't have enough vaccine. Because a lot of health systems in the continent are actually dependent on donor funding. And COVAX was promising 20% of the actual, promised demand. So obviously, whatever you do, if you're depending only on donor funds to procure these vaccinations, there would be inadequate supply. Then insufficient planning. Some of these things are taken as soft skills sometimes, but it all is interrelated. With insufficient planning, you always have a lack of funds, even in abundance. And as I said, when you're working in an environment that is low resource, you quickly realize that you can work with whatever you have, but if you haven't planned around it, it almost feels like you can't do anything, even if you've got resources sitting right there in front of you. Then also the lack of trained personnel, and this spans across the whole issue, whether it's the actual health personnel administering the vaccine, because it was a new technology, it was a new vaccination, new medication. So you needed to have people trained in what this is. The other thing was, because of the necessary vaccination, we were calling people back who are retired. And this was whether it's developed countries or developing countries, you'd still had retired health workers coming back to help, curb, to help vaccinate the population. And without funds, you can't do that. Then the last point, which was really sad and continues to be an issue, is vaccine hesitancy. And vaccine hesitancy, you'd expect, could be from a population level. But because of the way COVID actually started and the way it panned out, we actually had governments and leadership in some of the countries being very skeptical about how true this pandemic was and what was the intention and whether they should actually buy into all this. So both at government level, and the people who suffer the most are those who depend on government systems. Self-funded people are usually able to get something, independently. But when governments are hesitant, that's the majority of the population who are actually living below the poverty line who are affected by this. And as you know, a large population in Africa is dependent on that and lives below the poverty line. So that was really going to be an issue with vaccine coverage. Honing back to the inadequate supply. Just some facts. Africa actually has 1.2 billion people with 55 member states. And unfortunately, 99% of our vaccines are imported. Well, this really depends on what you're reading. Sometimes 90%, sometimes 99%. But the point is, it's a huge amount of vaccine that we're depending on actual importing. And it's not a small market. It actually forms a quarter of the global vaccine market. So it's important to look at it from two sides, in the sense that at the time that we needed something, Africa was pushed back and said, you're not important enough. But in actual fact, we do form quite a big market. But the other aspect that you need to look at it with cynical eyes is to say, if importing vaccines creates funding or gives a certain organization funding, then there is going to be some resistance for you to gain self-sufficiency. And it's really important to put that at fore. It's not going to be an easy ride of, okay, let's start producing vaccines and then that will be easy for us. No, there's somebody who's benefiting by Africa being a market for their product. So it won't be an easy ride to get self-sufficiency. The other thing that we have to be honest with ourselves is that vaccine manufacture is a very complex and expensive thing. So if you're not able to do the basics, it's really difficult for you to establish such a complex thing. And even now that you'll see in the subsequent slides, it's really the outlier African countries that are kind of piloting this because of just expertise, infrastructure, and so on. Realistically, it can't be achieved. And it speaks to the global picture of development. This is a wake-up call, or the silver lining of this was the wake-up call to say, it's not just about the intricate things. You've got to look at the global picture of how developed a country is, and it's a social and security issue as well. So at the moment, we only have 5 African countries who manufacture human vaccines. We've got a couple more that do veterinary ones. And even within these 5 countries, there are only some who do end-to-end, I think 1 or 2. Most of them are fill and finish. So you've got the vaccine produced somewhere else, and all you're doing is bottling and distributing, which again poses a similar problem if you're not able to do something from scratch. And really, as we've seen at this point in time, there's a lot of conversation about the failure of COVAX, but COVAX is like a from my perspective, COVAX is like a scapegoat. COVAX actually represents how a lot of health programs in Africa fail. So we see successes, so-called successes, but in actual fact, because they're not homegrown, because they're not tailored to the particular countries, there's a lot of failure to move the overall health of the continent forward. Very quickly, there's this really good article that was published by Davis et al. 2022. And, you know, it's really just highlighting the fact that it's not just about being poor or being less developed or having less money. We've got other countries in Asia. I'll draw your attention to the bottom of this illustration, as well as the top. The top is Africa there, with where you see most of the countries, including our Egypt, which is really, you know, one of our poster child sort of countries, is, you know, behind the graph when you compare it to other Asian countries that are poorer, you know, in terms of economic status and so on. So even our less wealthy Asian countries, such as, you know, Bangladesh and the Philippines, have achieved at least 50% coverage. Most of African countries are still below 10%. We're pushing it to say 16%, honestly, according to this article, realistically. Now, very, very quickly on the negative, before I move to the positive aspect, is there's another article that was published in the Lancet Infectious Diseases recently, and it's worthwhile reading. It's a modeling study that just tells you, you know, the disparity and in the lack of vaccination globally. What vaccination did in the COVID-19 pandemic is that it mitigated 14.4 to 19.8 million deaths in 185 countries, studied over a period of 12 months, or modeled into a period of 12 months. However, in low and middle income countries, we're working on a theoretical number that if we had achieved the 20% that COVAX had intended, 45% of deaths could have been averted. And WHO had a different criteria based on, you know, if everything was perfect and we were able to access. They wanted us to achieve 40% vaccination coverage. We would have averted 111% of deaths. When you look at the death contribution of the sub-Saharan continent, the absolute figures are not very good because there are many factors, but mainly it's a young demographic. And COVID, if you have an older demographic, you would have higher absolute contributions and the impact of mortality would be higher. But the point is, it didn't preclude the fact that we did lose a lot of people, even on a personal level. I mean, I have lost a lot of relatives from COVID-19. It's unbelievable. So, you know, in the grand scheme of things, we're actually, it's a senseless loss of life that we don't have vaccination or access to adequate vaccines in Africa. And this table coming from this article, just it's terrible. You know, the first part of the table shows you according to World Bank income groups, and there it goes to 3.57 for the low income groups. But when you look at the WHO groups according to continents, you can see what the BMJ article was talking about, because African region, vaccination coverage, 5.48. And the next region, which is Eastern Mediterranean, is at 28.1%, massive difference. It's just totally unacceptable. So now, where is the positivity in all of this? The point is, I think it's just woken us up to the fact that we cannot continue depending on the goodwill of others to survive. It's made us think about approaches on how to make, you know, our own vaccines and how to be a little bit more organic than copy and paste in terms of solutions. Vaccine nationalism was a major issue during the COVID-19 pandemic. You know, and in a way, it's justified. I mean, the politicians had to look at their electorate, the people who put them in office. People actually got kicked out of office based on the political unrest because of this social disruption during the COVID pandemic. So to a certain extent, they really had to safeguard their populations and ensure they had enough vaccines, they had enough boosters, they were on top of the technologies, whatever mutations were coming out, was the vaccination you know, adequate, and all those other things. So the best thing I think that happened was that we really woke up to the fact that no, this thing of pulling together depending on someone giving us, it won't work, even if we've got collaborative institutions like the WHO. So what now has happened is that there's an accelerated effort to invest in mRNA vaccine manufacture. And in terms of emphasizing on what mRNA vaccines are, is the fact it's better than the traditional vaccine sort of scenario because it's quicker to produce. And in our African context, that's where the skepticism came in. They said there's so many, so many diseases that we've been fighting all these years. How come COVID, how come COVID vaccination is a possibility in such a short period of time? So it was about understanding the fact that this technology has been around, it's been worked on, and basically opportunity met preparation, and COVID vaccine allowed us to utilize this technology. And Africa needs to invest in this. The problem, again, it all comes back to the dependent on donor funding and the lack of planning and self budgeting for these things. Is if a donor gives you the money, they'll tell you how to spend it. So what needs to happen is African countries needed to think about funding their own innovation, as hard as it may be, so that they can dictate what they want, and they're not being told to get entry-level technology, which is what happens. Radiotherapy machines get this, it's an entry-level thing because that's what you can afford, that's what's sustainable, but is it really, what we need? So, having mused about that, what two solutions have come out of this? So the first solution that came out was the fact that we have leading countries. I mean, it's not like we don't have countries that have the infrastructure and intelligence to accelerate these programs. So the idea was to create hubs where this could be developed for our scenario and our sort of environment. And then that would be south to south collaboration and transfer of intelligence on how to make these vaccinations. And after multiple consultations, 6 recipient countries were chosen. So Egypt was one of them, Kenya, Nigeria, Senegal, South Africa, and Tunisia. And they're supposed to build capacity. This the first institution is based in Cape Town under Afrigen, and the idea was to actually use freely available patent information on how to make the vaccine and basically work their way back and produce this in a legally acceptable manner without breaching the patents. The second parallel solution that came in with its own criticisms was the sort of turnkey solution where BioNTech brings fully made labs in 6 containers and sets them up in African countries due to their concerns about whether there's enough capacity, whether the quality assurance processes can be made. Most of the staff and infrastructure is from there, with the hope that some of it will be transferred into African hands at some point. So the first solution was more of, or is more of, an Africa made for Africa by Africans. And the second solution is still more of an investment from outside and still a bit of control from the other side, but with, the promise of a sharing of intelligence and so on. Anyway, the first countries to participate in this are Rwanda, Senegal, and I think South Africa would also participate in this thing. I think at the end of the day, the point is just the production locally, is a step forward. We're moving the needle forward, and we may not see the benefit. Actually, we will not see the benefit for this particular pandemic, but we will see it in other things. Like if we bring it back home to what we are here for today, which is cancer control, we've got cervical cancer, which is a raging problem in most of Africa, totally preventable by adequate, vaccination programs. Right now, we're singing a song of success in HPV vaccination in most countries, but in actual fact, when you compare it, I'm critical to say we are not succeeding. Our developed counterparts are vaccinating little girls, little boys, men, women, whoever wants to be vaccinated. We are still only vaccinating girls of a certain age range and also of two subtypes of HPV. So clearly, if the quality is still different, and it's a step in the right direction, but it's just not good enough. We've got to reach a point where we're actually able to be at par and have this equity issue solved. And I'm hoping that in the next generations to come, we're planting a seed, and part of what we're doing, documenting all this, gives a reference point for future policymakers as well. What are my key take-home messages? It's really just the long-term vision of self-sufficiency. It's important to keep on trying to put Africa to fish and not to give the fish. Then the other thing is the South-to-South collaboration. Again, this can only come with local and organic solutions from African countries. The COVAX program is said to have started in a bar in Switzerland between two men who are totally not African. I'm not sure how much time they spend in Africa. Whereas sometimes South-to-South collaboration allows it, where you say, okay, Zambia has got a lot of good glass factories already. Yes, they can produce the vials for the vaccine. South Africa can continue with the high-tech stuff for now. Senegal will produce the needles. And like that, you have this sort of cohesion and alliance in vaccine production that is Africa grown. We've done it with a lot of things in the SADC region. We've got our own economic zones. And I think we need to really accelerate this in terms of these things and really use the African alliance. But unfortunately, as I said, remember, we make 25% of someone's market. So they will always be that issue of, greener pasture somewhere. Then cheap is expensive. I know that's what we can afford and we need to move forward, but I think it's about time we stop trying to go through reinventing the wheel. If the UK is already at mRNA vaccine, let's go to mRNA vaccine. Let's stop trying to, go through the motions of going through the step-by-step. Cheap is expensive. Then nationalism is a reality of the world we live in, and it's not our place to judge when that happens. Our place is to do the best for our people. And I think the other thing that Africa needs to really invest in is its human capital, because this is also, by the way, thing that's not really brought to fore. And as long as they do not invest adequately in their human capital and understand that, then every time they set up infrastructure, they're going to lose that because there's just not that concordance. So again, it takes planning, it takes someone with a holistic view of these things to help drive the agenda. Thank you very much for your attention, and I look forward to our discourse.
Dorothy, that was an absolute masterclass. We were all absolutely riveted. I mean, we've got over 100 people listening now. It was absolutely extraordinary tour de force. Thank you so much. There's so many questions. I mean, maybe I can just kick off and saying, you focused a lot on the manufacturing here. I guess one of the lessons as well from the pandemic is the procurement, the logistics, and the distribution, and the huge challenges. Now, you're also a member of the Central Medicines List for Cancer and the World Health Organization, so you've seen this from another perspective. Yeah. What do you think? I mean, what do you think we know, or rather, do we know enough about the challenges for that within individual countries? And if not, what do you think needs to be done going forward?
Richard, that's a brilliant question. And I think I'm going to hone in of what you said about individual countries, because, what happens is that we tend to paint Africa as one, but because of how unorganized it's actually heterogeneous, and we should find solutions for individual places. Because if something is organized and it's the same, then you can take a solution and plant it anyway. But because there are so many different models in each African country, we really need to invest in understanding everything and not just say, oh, this is successful in Rwanda, and then call it Africa. So that's the first step. The first step is the recognition that individual approaches, and certain things are holistic, like getting experts together and getting them to go back to their countries. You can do that together, but it's really, you can't put solutions for Africa and say, this is what has worked in Rwanda, so all of you go and do it. That's, I think, is what is leading to our needle not moving forward.
It does speak, of course, to that need for the research funders, particularly to start focus on the second translational gap, implementation science, our services research, World Health Organization, NCDR and I committees. Everyone's talking about it, but the reality is it's not where the money is going. That's not where the focus of a lot of research programs are. I see.
Yeah, so thank you, Dorothy. That was absolutely fantastic. Just to our viewers, as Richard said, we've got over 100 people online now watching this, so we would welcome their comments, questions, suggestions for the speakers. Dorothy, I guess it's important also to stress the fact that, governmental interest tends to wane once these are not headlines anymore. So how are you and your colleagues going to try and ensure that that interest remains in developing the vaccine hub and, taking it forward? And just a corollary to that, the BioNTech the container labs, did any of those actually get established in Africa, or was that just an idea that?
From my understanding, Rwanda is well underway, and I have confidence in Rwanda systems, honestly speaking. So I do think we will see a completion and actual realization of that project. However, in terms of your question on how government, and that's why I think technocrats and politicians need to separate. And the truth of the matter is, I think sometimes we tend to blur that line a bit. The higher you go as a technocrat in a country, you would know better. Both of you are bosses. So it's the only way we do this is by keeping true to ourselves as technocrats. And I think that's why in my closing message, I said we need to invest in our human capital. We need to allow technocrats to do what technocrats do, and this lacks in African countries. Yeah.
Fantastic, Dorothy. Thank you so much. Absolutely fabulous. And obviously, we have some more questions as we go along at the end.
Great. Thank you. Thanks, Dorothy, again. And it's now well past midnight, I think, in New Zealand. Yes. So thank you again for staying up. So great. So moving along now, I think in the natural flow of things, I'm going to ask Dr. Fawad Qamar to speak next. Fawad is a consultant clinical and radiation oncologist at my own institution at Chowkatana Memorial Cancer Hospital in Peshawar. And Fawad is going to talk about innovations in cancer care during and beyond the COVID-19 pandemic and experience from a large cancer center in Pakistan. So over to you, Fawad.
Okay. Thanks very much, Dr. Aasim and Richard, for inviting me on this fabulous platform of London Global Cancer Week. I'm just going to start my slideshow. I hope you can see my screen.
Do you want to just put it on slideshow?
Yep, perfect. I have. So thank you. So the topic of my talk is innovations in cancer care during and beyond COVID-19 pandemic. And I'm going to share with you experience from working in Chowkatana Memorial Cancer Hospital and Research Center. Just to give you a bit of a background, Pakistan is a large country with a population of around 230 million people. And essentially, we get increasing number of patients with cancers from a wide, across the wide section of the population, with different stages and different tumor sites. And each year we treat nearly 6,000 to 7,000 new patients with cancer across our hospitals. Chowkatana Memorial Cancer Hospital at the moment is spread across 2 sites in Peshawar and Lahore. And we have got a huge third cancer facility being built in Karachi, and it will be operational very soon. And hopefully this will cater for a very large population from across the country. So I have no conflicts of interest to declare. So these are the objectives of my talk. So essentially how COVID-19 pandemic shaped the practice across our institute at Chowkatana Hospital, and how we adapted different strategies to counteract the challenge posed by COVID-19 pandemic. So all of these different interventions, if you like, were quite simple and small, but when you bring them together in the grand scheme of things, they had a huge impact in our response to the pandemic. So I'm going to talk about the concept of hypofractionated radiotherapy, how we adopted virtual clinics in our hospitals, how we switched to virtual multidisciplinary team meetings to provide for our patients ongoing clinical care, how we switched from intravenous to oral chemotherapy regimens to reduce the number of hospital admissions, how we introduced increasing number of day case surgeries, and what lessons have we learned from all these interventions that will hopefully shape our response for similar pandemics in future, and also to meet the demands of increasing population with cancer. So it was a very challenging time, to say the least, but COVID-19 was a real test of human resilience. And cancer patients, unfortunately, are very vulnerable to get severe COVID-19 infections. There were times in our hospitals when we had influx of a very large number of patients with severe COVID-related complications, requiring oxygenation, ITU admissions, and different sort of interventions. And cancer care is a very unique form of treatment because we all like our cancer pathways, and we want to care for our patients in a very organized way from point A to point Z. And COVID-19 was a huge challenge because it completely disrupted those cancer pathways. Also, there were times when across the hospitals, we had real shortage of skilled workforce because of the pandemic and the need for isolation once the staff members got COVID infection. That meant that, at the peak of the pandemic, we had a very low number of skilled workforce catering for patients with cancer as well as with severe COVID-19 infections. So there were challenging times, but very early on, we adapted different strategies quite successfully across our institutes, which helped to slowly dampen that challenge posed by the COVID-19 and, put the ball back in our courts and gave us an upper hand over the pandemic itself. So the first thing that I'm going to talk about, which is my area of expertise, is the radiotherapy and how we used hypofractionated radiotherapy in breast cancer. And as all of the cancer centers across the world, breast radiotherapy accounts for nearly 40% of all the treatments which are offered in our center. So that was the first thing that we wanted to target in terms of reducing the cancer waiting times and the treatment waiting times. Luckily, the Fast Forward trial, which was published in Lancet Oncology around May 2020, that was the perfect timing, actually. And that actually showed that giving radiotherapy over 3 weeks, essentially, it compared really different radiotherapy regimens. So it compared 40 gray given in 15 fractions over 3 weeks with 27 gray given over 5 fractions in 1 week with 26 gray given over 5 fractions in 1 week. And that showed that patients who received 26 gray in 5 fractions over 1 week had a non-inferior outcome with regards to not only the disease recurrence, but also the cosmetic outcomes. So that essentially the UK Fast Forward trial concluded that adopting the hypofractionated radiotherapy regimen with 26 gray in 5 fractions is a safe strategy. So we adopted that strategy very safely in our centers because we wanted to achieve optimal radiotherapy for patients with breast cancer whilst reducing the treatment time. So we were very successful in cutting down on the treatment time from 3 weeks and reducing it just to 1 week. We just didn't haphazardly introduce that change. We had a detailed discussion amongst different specialists, looking at all the available evidence and the need of the time. And then we introduced that change. We initially just restricted ourselves to patients with early stage breast cancer. Then we slowly expanded it to include patients requiring post-mastectomy radiotherapy, node-negative patients. We successfully treated our first patient in November 2020 when we were experiencing the first peak of the pandemic. And so far, we have treated more than 150 patients with this hypofractionated radiotherapy across our centers in Peshawar and Lahore. It has been a very successful treatment course because it greatly reduced the exposure of patients and staff during the pandemic to potential infection in the hospital. I mean, you can imagine that the risk of getting the infection whilst visiting a very busy cancer hospital nearly reduced to 1/3 by cutting down on the number of fractions required to treat this early stage breast cancer. That also meant that patients were more satisfied because they didn't have to come every day to the hospital for 3 weeks. And generally, we found that the patients have experienced very low toxicity from this treatment. So going forward, what we are now proposing or looking to adopt this treatment for patients requiring breast plus nodal radiotherapy treatment, but we will obviously wait for the results of fast forward nodal sub-study before we implement that change. It's just because we want to be very careful in adapting such strategies, and we want to make sure that we have had a good outcome for patients who have received early stage radiotherapy for early stage breast cancer before expanding that to include patients requiring radiotherapy for breast plus lymph nodes. We also treated a few patients with LINAC-based stereotactic radiotherapy for early stage prostate cancer, and that greatly reduced the treatment times for these patients from 5 to 7 weeks of radiotherapy to about 3 to 5 fractions of treatment. And that was again a very useful strategy. And we are looking at expanding that technique for other early stage tumors as well. So our other success story was the launch of virtual telemedicine clinics. We introduced that first in early 2020 in order to reduce the flow of patients and their relatives in the hospital, and to reduce the spread of the COVID-19 infection. It was a huge challenge, I tell you that, because both clinicians and the patients, they were not very comfortable at all with the idea of attending these clinics and running these clinics. It's just because as a doctor, we feel more satisfied in physically seeing the patients and examining them, looking after them, seeing them in person. And likewise, the patients feel more satisfied by seeing their physician in person. So it was a huge challenge in starting it. But again, it required quite a lot of coordination and discussions between different team members. And we decided to start this practice mainly for long-term follow-ups, breast and prostate cancers, which were relatively straightforward and required one visit every 6 months or yearly visits, because we thought that they're sort of low-risk patients who can be safely followed up in these long-term follow-up clinics. And once we gained more confidence and the patient got more confidence with this service, we then expanded this to include other tumor subtypes and patients on active systemic therapy. This has been a highly successful intervention. This also was patient-driven. So the patients, by attending these telemedicine clinics, they were constantly given the message that this consultation is meant to be a very thorough consultation, but at any defined time point, if they feel that they need to see their care provider in person, then there is no stopping them in coming to the hospital and getting physically checked out. So that gave them more confidence in the service, that there is a backup in case things don't go well as planned. So we came up with these models for patients both with long-term follow-ups after treatment and for patients who are on active systemic therapy. So just going through these models, basically. So patients on long-term follow-ups, the clinician, they arrange appropriate investigations in the clinics, including imaging or appropriate blood tests. The patient then gets a dedicated teleclinic appointment slot, and that gets messaged on their mobile phones. They get a link for that. During the teleclinic consultation, the physicians, they go through a detailed review of symptoms and investigations and address any concerns of the patients as required. And they constantly, again, educate the patients about the importance of self-examination in case of breast cancer, and for looking out for any symptoms that could be red flag symptoms. And if any of those symptoms, they required physical examination, then they were encouraged to come to the hospital. Otherwise, if the patients were all fine, they continued on long-term follow-up. In order to achieve that goal, our hospital IT system, they designed very specific templates for teleclinic appointments. And those templates had very detailed boxes to document all the symptoms and investigations of the patients. And that really helped the physicians a lot because that gave us the prompts to ask patients the right questions and to look out for the right investigations. And that became quite user-friendly. So that meant that we did not miss important clinical findings, and everything that we discussed with the patient in a teleconsultation got documented, and all the team members across the hospitals, they had access to those clinical notes on our electronic database. So taking that forward, we devised another model for virtual clinics for patients on ongoing systemic therapy. So for that, we wanted to adopt even a more robust strategy to make sure that we physically evaluate our patients before they start a course of systemic therapy. So all the patients requiring systemic therapy, they had a face-to-face consultation first, and the consultant, before COVID pandemic, the consultant or clinician, they went through a detailed examination and evaluation of the patient, looking at their performance status and all the relevant investigations before making a treatment plan for them. The patient then used to get an appropriate appointment for systemic therapy and a virtual teleclinic follow-up. Again, we devised specific toxicity questionnaires and assessment tools to make sure that all the doctors who evaluate those patients in teleclinic or virtual follow-ups, they go through all those toxicity assessments, and that gets appropriately documented in the system. If the patient didn't experience any toxicities during treatment or very mild toxicities, they were given appropriate advice, and they continued on this virtual teleclinic follow-up service whilst having the systemic therapy between those appointments in the hospital. At any point, if there were concerns about the clinical condition of the patient or the patient experienced grade 2 or higher toxicity, they were offered a face-to-face consultation with the clinician, responsible clinician, and appropriate decisions about treatment continuation or dose reductions were made in those clinics. So those modalities of virtual follow-ups, they helped us to greatly reduce the number of patients requiring to be seen in those outpatient clinics. That also meant that we didn't require a physical clinic room to examine those patients. And that also meant that a requirement for supporting an ancillary staff, it reduced at the time when we have a shortage of that staff during the COVID-19 pandemic. So as I said, patient satisfaction surveys during the pandemic indicated that they had a very good experience with these virtual clinics, and the patients wanted those clinics to continue. Bear in mind that because Pakistan is a very large country, so some of these patients had to travel from quite a long distance. I have come across patients traveling from nearly 400 to 500 kilometers each way for their consultation, which lasted for like 10 to 20 minutes. And that meant that patients don't have to pay for their journey. They didn't have to endure the pain caused by that long journey to come to the hospital for a regular consultation. And also the staff felt more satisfied, and they also gained confidence during the pandemic that teleclinic or virtual clinic is a safe service for the patients, and there is safety netting available in case things don't go as planned. So how we want to take it forward for future, and how we want to plan it beyond COVID-19. So I'm going to talk about synchronous versus asynchronous virtual clinics. So I'm going to discuss that subsequently. Also, there's a plan to use patient-specific secure portals for video consultations. We are also developing toxicity surveys and dividing them according to the tumor sites for patients with ongoing systemic therapy. There is also a plan for site-specific virtual clinics for different tumor sites. And beyond all, we are also ready to welcome artificial intelligence in our virtual health service. So just to touch upon what do I mean by synchronous versus asynchronous virtual clinics. So synchronous is real-time doctor-patient interaction through virtual media. So it could be a phone call or it could be a video call in real time. So that works really well for patients on ongoing systemic therapies, for those patients with complex needs requiring a doctor-patient interaction. And that can be done really easily through a video call or a telephone call through a secure portal. So we are looking at stratifying our patients and arranging synchronous teleclinic appointments for those patients who are on active treatment or who have complex needs. With asynchronous virtual teleclinic model, we are looking to develop specific portals, chat boxes, and dedicated patient-specific emails for those patients who have less complex needs and who are long-term follow-ups. So a classical scenario would be a patient having a blood test done for a PSA and then emailing us or sending a message through a dedicated chat box. That then would prompt a reply from the consultant, who would obviously look at all the investigations and would get back to the patient. That is not real-timed, and it would hopefully work really well for patients who are on long-term follow-ups. At any point, if there is an abnormal report or the patient doesn't feel well, then they can either be switched to a synchronous virtual teleclinic model, or they can be asked to visit the hospital in person. So that is one of the things which we are hopefully developing and launching in the near future to further streamline this service. One of the other things that we very successfully launched across our hospitals, and which was a real model of success, was virtual MDTs. Again, when COVID-19 pandemic struck, we were doing physical MDTs where clinicians and specialists from different specialties would be sitting in one room discussing about each and every patient who would walk in through a doors and making appropriate plans for them. So in order to continue that service at the time when it was really challenging to run a successful cancer service, we devised this virtual MDT service, and that required a lot of coordination between different team members, from the management to the IT service, to the clinicians and the admin staff. And it started off, with common tumor sites, including breast, but then gradually expanded to cover all the cancer types, including head and neck cancers, lymphomas, and the experience had been fantastic. One of the things is that it can be conducted through any secure electronic device. You don't have to be physically present in the hospital to run the MDT. So we had times when the clinicians were not feeling well with COVID-19, they were in isolation, and they were yet able to deliver that care to the patient from their homes by dialing in to the virtual MDT from their mobile phones or iPads and making all these decisions for the patient care. So we thought it's a huge success, because even when the clinician, they're at home isolating, looking after their relatives, or looking after the relatives with COVID-19, they can still be a part of the team and delivering secure and safe care to the patients. Our organization is very unique because it is spread across the whole spine of the country. And this virtual MDT has given us a brilliant platform because it has brought together the skill mix from all the different organizations under the Shaukat Khanum umbrella. And it has basically made the geographical boundaries really blurred. So I can dial in from Peshawar, my colleague can dial in from Karachi, and we can talk about the patient sitting in Lahore and make the plans for them, which I think is fantastic for our country. And it really gives us a model of care for other developing countries and how to successfully run an MDT virtually. And it has been a huge success for us. So we also brought in changes to our systemic therapy regimens. So 5-FU, infusional 5-FU-based chemotherapy is the backbone of treatment for patients with gastrointestinal cancers, and GI cancers form nearly 30% of our patients requiring systemic therapy. However, these are complex treatments requiring PICC line insertions and admissions for or admissions for up to 48 to 72 hours to deliver the treatment in case they don't have a PICC line. And also we had the added problem of admitting these patients in case they didn't have a PICC line insertion. We had a long waiting time for the PICC line insertion because we had shortage of the skilled workforce during the pandemic. So it was a real challenge to deliver those systemic therapies in time to those patients. So we made a decision to switch those infusional chemotherapy regimens to oral treatment safely and effectively and in line with the current best practice, internationally accepted protocols and guidelines. So we were able to switch from infusional 5-FU to oral capecitabine based chemo regimens in around 70% of the patients with GI cancers. It thankfully didn't reduce the efficacy of our treatments, but it's greatly improved patient experience because the patient only had to come once every 3 weeks to pick up their tablets, had a blood test, and then go home. They were properly told about how to take the medications, how to look out for the side effects. They had an appropriate teleclinic follow-up appointment already given to them at the time of chemotherapy dispensing. It also meant that the patient had reduced length of stay in the hospital, and it was very good. One of the other changes that we introduced at a smaller level were that we started a small number of day case surgeries across our hospitals. Again, we wanted to be safe, and we wanted to make sure that we provide surgical care to the patient based on their clinical needs. So we restricted ourselves to only patients requiring day case partial nephrectomies or breast conservational surgeries. So less complex patients with less complex needs. However, once we get confidence with this practice, we are looking at further expanding this to include other tumor sites. We're also doing some studies and audits to make sure that we are complying with international guidelines. This also improves patient experience and resource utilization at the time of COVID-19 pandemic. As I said, this is a service which is still expanding based on the accepted standards and guidelines. So how did we put it all together in a virtual world and making sure that there's a good mix of the virtual and physical interaction with the patient safely? And how we did that during the COVID pandemic and how we are looking at expanding it further in future. So we came up with these models for patients requiring different treatments across different tumor sites. So a very simple model of patients requiring breast radiotherapy at the time of COVID-19 pandemic. So all new patients with early stage breast cancer, they used to get discussed in our virtual breast MDT. Once a decision was made that those patients required breast radiotherapy, then we had a face-to-face first consultation with the patient, and we gave them the start date of radiotherapy treatment. The patient then presented to our departments for hypofractionated short course of radiotherapy treatment, which finished over 5 days. And if there were no toxicities, they were discharged to a virtual teleclinic program where they had an ongoing telehealth follow-up. At each time point during their interaction with the healthcare provider, they were constantly educating about how to assess the toxicities of the patients and also how to assess the toxicities and how to be breast aware and make sure that we don't miss on the important clinical symptoms of recurrence. So just in summary, we adopted a number of different strategies across our hospitals for providing effective cancer care in the face of growing demands during the COVID-19 pandemic. We are constantly expanding those services and the lessons that we learned during the pandemic. And as I said, we are trying to develop synchronous and asynchronous models of virtual teleclinics to cater for increasing number of patients and with different needs during the time of cancer treatment and for their follow-up. That obviously requires constant patient and staff education. We were also successful in developing robust tools for data collection, and that really gave us a platform to conduct a number of studies and audits to further expand this service. Finally, artificial intelligence As we all know, it has made inroads in the diagnosis and treatment of cancer. We are looking at adopting that in our ongoing cancer care pathways, and also to explore its role in follow-ups. So we are looking at designing computer-based algorithms for patients on long-term follow-ups, especially those requiring regular blood tests, and to devise those algorithms to pick up early signs of recurrence on their blood tests. With that, I thank you very much, and I would want to share a picture from Pakistan. This is a very beautiful lake in Kashmir, and it really reminds me of heaven. You feel like the top of the world, and I would really love if you visit our country and see those beautiful sights spread across the whole country. Thank you very much.
Absolutely amazing. Absolutely. I have to say, we both looked at that and thought we wish we were there right now, actually, rather than sitting in this rather airless office in Guy's Hospital. But, well, thank you very, very much indeed. Masterful presentation. Just thoroughly enjoyed it. We've got a bit of time for questions now. And Raúl, I see you've got your hand up there.
Yeah.
Go ahead.
Thank you so much, Dr. Fawad, for this wonderful presentation. Just wanted to ask you about the sustainability and the acceptability of innovations. Let me talk really about three situations. In our case, radiotherapy is paid to doctor based on the number of sessions that are provided. So the acceptability during the pandemic was high, but after the pandemic is coming back to the same situation before the pandemic, and a lot of negotiation and deals with this issue. The second situation is the teleconsultation. So we started with the teleconsultation as well, and the acceptability during the pandemic was really high. But after that, patients are again saying that they prefer, most of them, they prefer in-person follow-up because they don't feel they're safe with the teleconsultation. The acceptability have come down after that. And the third one is the acceptability by the government. So we didn't need a special regulation for hypofractionated radiotherapy. We had a very restrictive regulation for telemedicine before the pandemic, so it was totally relaxed during the pandemic. And after the pandemic has been, again, moving back, not so much restrictive as before, but some restrictions for implementing in a sustainable manner telemedicine. But something was never accepted by the Colombian government during the pandemic for the provision of chemotherapy at home, that we proposed that, and it was just regulated in this year. So acceptability by doctors, by patients, and by the government, I think this is quite critical for sustainability of innovation. I don't know if you have a comment on this situation. Thank you.
Thank you very much.
So I'll just come in on that, Raúl. Fawad, are you going to say something?
Yes, I was. So, we have a very unique model of healthcare at Shaukat Khanum Hospital. Ours is a charity-based hospital. We also had the same challenges as you experienced in Colombia. There was a lot of resistance from the clinicians as well as the patients in adopting those changes. And it just didn't come overnight. So we had to ask all the stakeholders to sit together. Ours is a unique organization because we have 85% of the patients treated completely free of cost, and only a small fraction of patients paying for their own treatment. But we didn't distinguish between the patients requiring free treatment or those paying for their treatment. We gave them the same standard of care. So if they required hypofractionated treatment, we gave them that treatment regardless of their position and ability to pay. And I think that model should really be adopted across the centers, especially in countries where they have insurance-based practice. As you very rightly mentioned, the clinicians and the institutes have a vested interest in prolonging the course of treatment and sticking to the current standard of treatment, which was a 3-week-long course of treatment. But we have to look at what's best for the patient rather than what's best for the institute or the clinician. So we learned a number of lessons. And as you very rightly pointed out, that cancer, a diagnosis of cancer really hits you hard. And the patient wants to see their clinician very often in person for reassurance. And that is a very human instinct. And to overcome that instinct and to switch to a teleclinic model where you either listen to a consultant or see them remotely was a huge challenge. But we accepted that challenge and we learned a number of lessons. We refined the techniques required to improve the patient experience. We are not perfect, but we have learned a number of lessons and we are hopefully built up on that.
Raúl, if I could just add to that, in fact, sometime before the pandemic, initially, we also followed the North American or the American model of paying by fraction or charging by fraction. But we had actually moved prior to the pandemic to a system where we charged or costed the radiation procedure based on the cognitive effort of the radiation oncologist in treatment planning. So radiation oncologists were paid based on their the time it took them to plan the treatment and not on the number of fractions, because we felt that that was not really a function of the radiation oncologist, but rather of the technologists and physicists and the machine.
An innovation as well, I mean, I would say.
With regard to telemedicine in particular, Fawad has covered all the, I think, all the challenges that we face there. But one great advantage we had was the fact that patients come from all over Pakistan and even from Afghanistan. And as he pointed out, sometimes they've traveled hundreds of kilometers for what is a 10 or 15-minute consultation. So actually, over time, they have grown to really value this as an alternative because it's much cheaper for them. It's easier. Patients don't come alone. They come with several family members. So there are economic and other disruptions that occur for the whole family each time they have to come to Lahore or Peshawar for an outpatient visit. And as Fawad said, we built in safety mechanisms so that we alternate physical visits with telemedicine visits. So you can't just be on telemedicine follow-up for 2 years at a time. It's alternate visits are in person usually. So, but these are ongoing challenges. And just with regards to the EMDT, the other thing I'd mention is that that has been such a great success actually, that we've had interest from other hospitals in Pakistan and again from Afghanistan of people wanting to link in just to see how it's done so that they can then take this model forward and do it in their own institutions. Anything else? No, I think otherwise we need to move forward in the interests of time.
Thank you very much.
So we've saved the best for last.
Thank you.
Dr. Debbie Mukherji from the American University in Beirut and the Clemenceau Medical Center in Dubai will now be speaking on redefining global cancer research priorities after the COVID-19 pandemic. Debbie, it's over to you.
Thank you very much for that very nice introduction, and thank you for inviting me to speak on this panel today. I'm going to be presenting the work of a large team involving Professor Sullivan, who's with us, Dr. Louise Fox, Dr. Mika Hemmelrich, Dr. Werner van der Pooy, and we also have Chris Booth here on the slide. We recently presented these data, which are very preliminary, at the World Cancer Congress, and these are currently being written up for a publication. So this is a project about redefining global cancer research priorities after the COVID-19 pandemic. It's a project which was part of the COVID-19 Global Cancer Task Force that we've already heard about. And it's something that we hope that everyone can have an input in, and moving forward to see how we can improve and prioritize what really matters in global cancer research following some very difficult times. And we've heard some really inspiring presentations from my colleagues about how we've managed to navigate this pandemic, and some of the changes such as telemedicine, different ways of healthcare financing, different ways of radiation fractionation that we'd like to move forward with. But one of the priorities that we thought about, or one of the difficulties, was this issue of cuts in cancer research funding. This has been written about by several authors and something that we were acutely aware of as we moved through. And this is the project called Reprise that our group have carried out to look at the impact of COVID-19 on global cancer research and to have some suggestions which are really based on a very broad activity of global consultation, how we can move forward from the pandemic situation to the post-pandemic situation. So we know that the pandemic, and we've heard, has had very wide-ranging practical and economic effects on cancer treatment, but also on cancer research activities. We know that funds from research and government agencies, NGOs and charities are expected to be and have been significantly reduced. And the costs of undertaking cancer research have significantly increased. And we've seen this global economic crisis in terms of energy costs, in terms of inflation, cost of living. We do not expect any increase in research budgets, certainly from the public sector, to be materializing anytime soon. And so we really felt that given all the things that we'd learned about global collaboration during the pandemic, we really needed to get together and redefine the priorities in global cancer research to inform the strategy moving forward. So the aims of this project were to define cancer research priorities, taking the emergent landscape of the COVID-19 pandemic into account, and very much the localized concepts within low and middle income countries. And we've used this broad term LMIC, which is very problematic. We are very much aware that every single healthcare context is very different. The context in Pakistan compared to Colombia, compared to Zambia, compared to Lebanon. And so although we don't like the term LMIC, we've used it as a catch-all based on World Bank classifications for this particular project. And we also wanted to collect information about the impact of the COVID-19 pandemic on cancer research globally. So this is a large body of work that I'm going to be running through some of the results in a very abridged fashion. This project comprised a systematic review, a snapshot questionnaire of the task force members, an extensive bibliometric analysis, looking at some previous research that had been done on current research priorities for emerging countries, and then that all fed into a modified Delphi process, which we will share the results of. So first of all, the systematic review. This was looking at a qualitative study of events to inform mitigation strategies. The conclusions of this systematic review were that there were going to be extensive both practical and economic effects on the field of cancer research. And we should really look at how we can mitigate some of these exacerbated cancer disparities. And Dorothy mentioned some of the issues with vaccine access, the inequities and advances in digital health, but also we were quite interested in the new areas of research related to the intersection of cancer and COVID-19. And I think it's really interesting that Richard Sullivan mentioned that a lot of the global research on this had come from task force members. And really, we were the only group that were focusing on researchers in the developing world, because a lot of this COVID-19 and cancer research had been done in the context of North America and high-income settings. So moving forward to our snapshot questionnaire, this was actually presented at the specific AACR COVID meeting in March 2021. This was in the height of the pandemic. We were all working virtually, and we were really getting some information about how, at the time, cancer research had been impacted. And we found that there were quite broad-reaching results and impacts due to the lockdowns, due to deprioritizing cancer research. So this was something that we knew would have a sustained, prolonged impact. Moving forward to a bibliometric analysis, this was performed with the team of Richard Sullivan at Guy's and Grant Lewison, who has a database, a pre-existing database, which we interrogated to look specifically at COVID-19 related articles in the Web of Science. This was between January 2019 and February 2021. And we wanted to understand the type of research that had been conducted and the impacts as measured by outputs, albeit a very early indication. So during this time, we identified over 1,500 publications. A majority of those were reviews, opinion pieces, or looked at modeling the impact of delays to diagnosis and treatment. Around 25% were looking at managing COVID-19 risk in patients with cancer. And as expected, more than 70% had come from high-income countries. There was no evidence of a reduction in global cancer research output in 2020, but we felt there would probably be a lag effect. we did see a shift in research focus rather than a decline in absolute output. We mentioned that we saw, as expected, a very low contribution from low and middle income countries. And we really wanted to consider the potential for the gendered impact of the pandemic as vital to addressing these disparities moving forward. And there's lots of data about how particularly female researchers have been adversely affected with extra responsibilities at home during lockdowns. And really one of the key messages that we felt strengthening global multidisciplinary cancer research partnerships with teams from very diverse backgrounds would be essential to prevent this widening of cancer inequalities that we were concerned about seeing. So moving on to looking at the current research priorities, and we based our Delphi questions on a really comprehensive article from Dr. Pramesh and colleagues, published in Nature Medicine in 2022. So this looked at 5 areas which were thought to be priority areas for low and middle income countries, namely reducing the burden of late presentation of cancer, improving access to affordable care and outcomes, improving health economic assessments, quality improvement and implementation science research, and leveraging technology to improve outcomes. So these were a panel of experts that had been consulted regarding these particular research priority areas. And this is how we based our Delphi questions. So moving on to the modified Delphi process, this was presented and managed by Dr. Louis Fox from King's. This is quite an extensive sampling method, and we really wanted to sample globally people who are really living and working in low and middle income countries, and experts who really understood the context of what is needed in terms of moving forward the research questions that matter to them. And the aims were to also consult patient organisation representatives to ensuring that the priorities are the ones that will really deliver for patients. And I think that this is a really helpful input by consulting patient representatives to make sure that we're not just looking at scientific or academic things, we are really looking at the questions that need answering for our patients. So the objectives were, as I've mentioned, to produce an understanding of the general cancer research priorities, particularly in low and middle income settings, acknowledging the ongoing systems and economics impacts of the pandemic. And also we wanted to use this opportunity to produce an understanding of priorities related from this transition from pandemic to endemic in low and middle income countries, and the implication of this process for people living with cancer. Based on the principles of Delphi, we had 2 rounds, data from round 1 feeding into round 2. This is just an infographic about how we did this. We fed all the data from our previous work into these questions. Participants were invited to review the proposed questions, priorities, and submit additional priorities. And these were ranked, resulting in a priority list. We had, thankfully, a very global survey sample, and this was really due to the efforts of Louis and the team and the contacts of the Cancer and COVID-19 Global Task Force. Regarding general research priorities, these were the top 8 according to our respondents. These were given points, and by far the top one was research into strategies to adapt guidelines or treatment strategies in line with the availability of medical resources, and particularly this was thought to be important for systemic therapy. Construction and implementation of high quality cancer registries without data, which is very lacking, particularly in low resource settings, we cannot really inform effective policy. Research focusing on the primary and secondary prevention of preventable or potentially curative cancers, investments in end-of-life care and palliative care for cancer patients and their families, better value, more affordable cancer care strategies, health systems research, addressing the implementation of cost-effective and evidence-based cancer prevention, screening and treatment strategies in low resource settings, investment in professional training and research capacity strengthening, and also cancer-specific risk factors driven by geographical, lifestyle or exposure, in these settings. So these were the top 8 priorities among a list of a huge list, according to our global panel of respondents. And in terms of the cancer and COVID-19 related priorities, there were top 5 were strategies to incorporate what we've learned during the pandemic that can be maintained. And it's interesting to see that this is how the conversation has been quite focused during this panel. Research examining how interruptions to treatment schedules could be mitigated or avoided, cost-effective strategies to reduce morbidity and mortality associated with COVID-19 infection in patients with cancer, informing risk mitigation and preparedness for future pandemics, and data collection on the impact on screening, diagnosis and treatment, specifically in low and middle income countries. So I think we came out at the end with some really quite sensible, logical and important points. We also sought the feedback from patient representative organisations, including World Ovarian Cancer Coalition, Fight Bladder Cancer, and the Advanced Breast Cancer Global Alliance. And the broad sentiment was in agreement. The top priority in each category was very important and consistent with their experiences and previous work. Particularly some really interesting interventions, that lower cost treatments were very important, particularly in parts of the world where patients are self-paying. The economic case, the word expenditure should be replaced with investment, which is very important when thinking about the broader aspect of cancer control, and also registry infrastructure, which unfortunately is mainly usually government funding and can possibly fall down on the priority list in low resource settings, but it was also recognised by patient representatives that this was extremely important. Climate crisis and the impact of climate crisis was missing from the list, and that was highlighted by our patients. Very disruptive, particularly in low resource settings, and it's something that we should all be aware of. There's an opinion expressed that cancer literacy should be higher on the list to be impacting patients a great deal. Healthcare professionals' quality of life was not prioritised on the list, and it was really interesting to see that came from the patients, that the quality of life of healthcare professionals should be prioritised, and research into that. Collaboration and grant support was felt to be important, and we all agreed, and agreement with the COVID-19 top priorities, strategies to incorporate what we've learned from this pandemic that can be maintained. That was thought to be very, very important. So the conclusions, this is really the first globally representative exercise establishing cancer research priorities for low resource settings. We really had extremely valuable input from patient representatives. And I think that's something that I personally learned a lot from, that we have a lot to learn from our patients, even when we are thinking about research and research questions. We should really base our research questions on what's important to patients in the end, and highlighting the importance of our diverse teams, the importance of context-specific research questions driven by researchers and patients on the ground. And we hope that these results will inform a framework for funding agencies moving forward, so that we can make sure that with the limited resources available, that the research that's funded moving forward is really impactful and important for both patients and researchers. So we'd like to acknowledge a huge number of people that helped us to formulate this Delphi exercise. And of course, acknowledgements specifically to the team, Dr. Louis Fox, who led everything for the data collection, Richard Sullivan, Mika Hemmerich, and we'd be very happy to take any questions. Thank you very much.
Debbie, absolutely brilliant. Thank you very, very much. I mean, it's extraordinary. And I should say to those listening, the importance of this has already been recognised by the World Health Organization, because the last prioritisation for research exercise was done was actually in 2008, and it was actually quite poorly done. And this is going to be a really important piece of work in helping shape priorities. Actually, priorities set, as Debbie said, from the country level. Before I hand over to Aasim, I mean, can I just ask you this question about the patient organisations you brought up here, and the kind of also kind of tying to what we've heard before about digital literacy and engagement with patients and patient organizations to understand what the research questions are and what the key areas we still haven't understood. And we talked about sort of digital psychology, confidence and trust. What's your sense about what's missing from the research ecosystem when it comes to engaging with patients and patient organizations?
I think that as we've mentioned, traditionally research questions have been formulated by senior researchers, often not working in low resource settings, and unfortunately this has just been a tradition. We know that, and from my experience, a lot of the funding has come from high-income countries, and the research is shaped or prioritized by teams in these high-income countries that need a partner in an LMIC and hook up with one. So I mean, we really learned that this is the wrong way around. This is completely the wrong way around. We need to perhaps start with the context. What's really important to the patients on the ground and the people that look after them. And I think today's webinar has really highlighted the specific challenges that were actually during COVID-19 that were overcome by people working with global consultation in their own individual environments, with a lot to learn moving forward. So I think we need to turn things on their head. We need to empower the patients and the people who are looking after them in their specific contexts, learn from the digital connectivity that we have really leveraged during the pandemic to work together to make more impactful change. I personally learned a lot from this process. I think it's been really eye-opening about how we can work together. We've published together, we've made some very impactful things for impacting policy, and that's all without a huge amount of funding, just with some time, a half reliable internet connection. So yeah, and absolutely. I think we've all got a lot to learn and to use this moving forward. And I'm really pleased because when we first thought about this webinar, everyone's sort of forgotten about COVID-19 and they're going around without their masks on. But actually we have a lot that we can take forward and continue to work together.
Yeah, beautifully.
Yeah, I think it's amazing that it came from the patients, the mention of climate crisis, because just in Pakistan in the last few months, everyone's heard about the devastating floods we've had there, and in a sense they've wiped out the infrastructure in a matter of 10 days, in a much more devastating way than COVID ever affected us, quite honestly. So that is the new challenge going forward. So it's fantastic that came up, and the cancer literacy came up as well. I thought that was very interesting too. And it's surprising that as clinicians, none of us suggested those from all across the world. All the respondents never mentioned either of those. So thank you very much, Debbie. That was really fantastic. We've only got, I think, 5 or 6 minutes left. I think there's maybe a question.
So just double check questions on.
Yeah, there's a question from Dr. Farhana Badr. I don't know if she will be able to ask it live, or does she need to
Q&A?
So she's asked, I understand that cancer registration was not a priority either. So this was on our list. It was one of the priority areas that had been identified by the global panel, and the patient representatives agreed. We've been working on this as a team, and the team from IARC is also supporting capacity strengthening for global cancer registration. But one of the main issues is the government prioritization and funding. So I think this coming from patients and researchers leads us to put some pressure. Without data, we can't move forward in terms of impactful policy. So I think as a community, this is something to really prioritize. We get very excited about the latest fancy equipment and medications, but without that basics of data, we really won't be able to move forward in terms of our policy making.
So Raúl and Dorothy, maybe you can comment on, do you think the experience of COVID-19 in countries has changed the dial in terms of the need to collect data for surveillance more broadly, and that's going to have an impact, you think, on hospital-based systems, or have people gone back, as you say, to the old ways and just ignored this as a priority?
Yeah, so I can speak from the Zambian perspective. I think in saying that I honestly feel that it has changed the dial and it's emphasized. So we had a platform of data collection based on the HIV pandemic. So that was the lovely thing about organic working, in the sense that the locals kind of led the solutions they wanted to see for COVID-19. And in a way, I think for Zambia, it's helped, in some of the successes. So to answer your question, I feel yes, in Zambia, in terms of data strengthening, COVID has helped, and we use the platform that's known to us through the HIV pandemic. So a lot of coordination with that system.
Raúl, what do you think from Colombia's perspective?
Yeah, I think that's something interesting from our country. During my presentation, I showed you two different sources of data. One, there's a notification system from insurance companies to the government, and the other based on the traditional population-based cancer registries. And the discussion is the timeliness of data, because the cancer registry are actually collecting data, and then I would say, I don't know if somebody working on that like Freddie would say, would punish me, but it's kind of old-fashioned and taking a long time to produce very robust data and then verifying everything. And but during the pandemic, we needed, we needed a different kind of information, more rapidly produced, and it was a huge, and it is currently a huge discussion. The main source of data should be stay on the population-based cancer register, and to be a different kind of notification or other kind of system. And I think maybe the language between both systems could be have a better communication we use in a better manner, or the advancement on information system and all the tools we have right now.
Now, it's an extremely important point. As you said, if it's not actionable intelligence in a timely manner, it's not going to help inform our mitigation strategies, and changing those data architectures is critical.
Yeah, so in Pakistan, the last government actually launched a health card, which covers the vast majority of the population in 3 of the 4 provinces of the country, which provides heavily subsidized treatment all through state-sponsored insurance. So I think we may also eventually be moving towards the sort of model that you described in Colombia, Raúl, although obviously it's very early days yet. But these sorts of data streams are going to become more and more available all around the world, I think, as time goes on, and to some extent may supplant earlier means of gathering data. So it may help to short circuit in countries like ours, like Dorothy's mention of the vaccine development, that you don't need to start from the first step. If everyone else is already at mRNA, you can do the same. And so similarly, I think some of these newer means of gathering data may supplant the earlier traditional models. So this is a very exciting area to be working in for the future. And I think there's lots of stuff that the COVID-19 task force can think about and do. And we welcome participation from all the other people that are online today and that hopefully have seen this on Facebook. And I think it'll be available on Facebook later as well for people to view. So we've just got 1 minute left. So any closing thoughts, Richard?
Just to say thank you all for being here. I hope you realize you just listened to an absolute masterclass in lectures. This is the extraordinary thing to Dorothy, Debbie, Dr. Fawad, and to Raúl. Amazing lectures, and people will be listening to these for many years to come. Thank you so much, Aasim, for his leadership in this as well, and putting this all together. It's been brilliant, and the aim of the game really is to springboard even more research into this area, and to keep this particular group going together, looking at resilience, mitigation for not just infectious diseases but disasters as well. And I think we've really hit on something extremely important that's actually led and co-developed in the countries where it actually matters. And I think taking Deborah's last point here, that's the most important thing. And if you're a massive research funding organization, if you're Bill Gates and you're listening to this, this is what you need to sort of look at. And these are the people on today who need to be funding for taking this forward, because it's the only way to change the policy dial. So thank you all very much, and thank you so much to Aasim.
Thanks.
Close now.
Thanks.
Time's up.
Thank you.
Bye-bye.
Thank you.
Okay, bye-bye. Thank you so
Bye.
much.
Thank you.